Hello, I'm Joyce O'Shaughnessy. I'm the Celebrating Women's Chair in Breast Cancer Research at Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas. We think of CDK4/6 inhibitors as being useful for patients with ER-positive, HER2-negative metastatic breast cancer. But it turns out that there is an IV CDK4/6 inhibitor being developed in triple-negative breast cancer in the metastatic setting. And the name of that CDK4/6 inhibitor is trilaciclib. And I had the privilege at San Antonio 2020 of presenting the final overall survival data in metastatic triple-negative breast cancer patients, combining the trilaciclib with a standard chemotherapy regimen, gemcitabine and carboplatin. So why combine a CDK4/6 inhibitor with chemotherapy for TNBC? Well, it turns out that trilaciclib has recently been approved by the FDA for small cell lung cancer patients receiving etoposide and a platinum to prevent myelosuppression, to preserve marrow function. And so that was our hypothesis. With gemcitabine carboplatin, as you know, there's cumulative myelosuppression. Perhaps giving trilaciclib before the gemcitabine carboplatin could lead to less in the way of cumulative myelosuppression, less dose reductions for the patients. And so patients with pretreated triple-negative breast cancer were randomized to standard gemcitabine carboplatin at 1,000 milligrams per meter squared day 1 and 8, and carboplatin AUC of 2 days 1 and 8. That was the standard arm. In arm B, patients received IV trilaciclib, which has a half-life of about 14 hours. They received it 30 minutes IV before each of their gem carbo doses. And then there was a third arm, arm C, where patients received 2 doses of the trilaciclib prior to each gem carbo dose. So they received trilaciclib before day 1 and before day 8 gem carbo, and they also received it 30 minutes before gem carbo, each gem carbo dose. And the results of the trial showed that there was actually no significant improvement in myelosuppression with the gem carbo. The endpoints of duration and occurrence of grade 4 neutropenia were not reduced significantly with the addition of the trilaciclib to the gem carbo, and it didn't make a difference whether it was 1 day or 2 days before each dose of the gem carbo. So the primary endpoint was not met. But interestingly, the anti-tumor efficacy of the gem carbo was better in combination with trilaciclib. It didn't seem to make a difference whether it was 1 dose or 2 doses of the trilaciclib before each gem carbo. But for example, with regard to objective response rate, with gem carbo, it was 29.2%, which is what we would expect. And putting the 2 arms together of the arms B and C, or groups 2 and 3, the objective response rate was 44%. Likewise, with progression-free survival, the median was 5.7 months with gem carbo alone, and was 9 months with the addition of the trilaciclib. That was not statistically significant. The big surprise here, now looking at the final overall survival data, is that the median overall survival with gem carbo was 12.6 months, which is what we would expect, and was 19.8 months with the addition of the trilaciclib. And the hazard ratios were very good at 0.37, and that was statistically significant. And we can see the curves pull apart. Looking at the Kaplan-Meier's, both arms with the trilaciclib were superior and statistically significant, even looking at the arms individually compared to the gem carbo with regard to overall survival. We also looked to see in this triple-negative population whether it made a difference if the breast cancer was PD-L1 positive versus PD-L1 negative, and it didn't. There was an improvement in survival regardless of the PD-L1 status of the breast cancer. There was a very intensive analysis of the immune system done on the trial because the hypothesis is that the trilaciclib is protecting the immune cells from the cytotoxic effects of gemcitabine carboplatin, putting them into a G0, preventing them from going from G1 to the S phase, because it's a CDK4/6 inhibitor, which inhibits that transition from G1 to S phase, thereby protecting the immune cells. And what in fact was found is that there were an expanded number of clones among the responding patients who received trilaciclib, suggesting stimulation and activation of the immune system in those who benefited from the trilaciclib and gemcitabine carboplatin. And the reason that TNBC was chosen to ask this hypothesis of protecting the immune system with the trilaciclib is because CDK4/6 inhibitors require intact RB in order to cause cell cycle arrest. And you don't want to cause cell cycle arrest of the cancer. You want the gemcitabine carboplatin to work because the cancers are proliferating, and because most triple negative breast cancers are basal-like, and basal-like breast cancers have a loss of RB function. And the hypothesis was, and this was borne out in preclinical studies, that trilaciclib would not inhibit the proliferation of triple negative breast cancers. And that appeared to be the case, looking at even the luminal apocrine TNBCs in this study doing intrinsic subtyping versus the basal likes. It did not look like there was any diminution of the benefit of GemCarbo across any of the TNBC subsets that were evaluated. So it really looks like the addition of the trilaciclib to GemCarbo is enhancing anti-tumor efficacy compared with GemCarbo alone, with a statistically significant improvement in overall survival, regardless of PD-L1 status and regardless of the TNBC subtype. The immune subtyping analysis from this trial and the T-cell receptor sequencing suggests that the trilaciclib given prior to GemCarbo is both preserving and enhancing immune cell function. And therefore, additional phase 3 study is clearly warranted to follow up on this observation of an improvement in survival with the addition of trilaciclib to gemcitabine carboplatin. And that phase 3 trial, called the PRESERVE trial, is now getting underway.